So now let's move on to the training. Ashley Metzger is here to present to us. She's a licensed professional clinical counselor supervisor. She received her master's degree from Xavier University in clinical mental health counseling in 2014. She began working at BrightView Health in 2016 as a counselor, where she helped develop BrightView's pregnancy and new mom program and was promoted to a supervisor in 2017. Since beginning work in the field of addiction, she quickly developed a proficiency for working with a specific cohort of patients who are pregnant. Through her practice, Ashley has been able to develop a gender-specific curriculum of pregnant women suffering from drug addiction, which focuses on the unique needs of pregnant women in recovery, along with the additional demands put on their bodies and hormones during pregnancy. Ashley, you can take it from here.
Awesome. Thanks so much, Ben. Thank you so much, you guys, for giving me this opportunity to share some information about BrightView and what we do, as well as some education about what it means to be a woman in addiction, being pregnant, and then being pregnant in addiction, because they're very separate but very connected things. After giving this training on Tuesday, I realized that maybe I should probably preface with a few things before we get going into the PowerPoint that I've got. Ben and Nikki are going to be hopefully, again, awesome enough to help me out if you guys have questions as we go through. I'll be pausing every couple of slides to make sure I haven't missed anything, but I'm luckily technology enough that I can share my screen, and that's probably about where my skills end for that. To give you guys a little bit more background about BrightView, we now have, I believe, 32 locations in both Ohio and Kentucky, Zanesville, London, Lexington, and we're probably just going to keep going more and more. So if there's not a BrightView close to you now, just wait, and there probably will be soon. Otherwise, we offer virtual services, telehealth services for medical appointments, clinical appointments, just about anything that we can do to reach the population in need, because as there is no boundaries for the disease, we kind of hold the same philosophy. We want to have no boundaries and no barriers for patients to be able to get to us in our services. With that, I'm gonna try and do the screen share thing again, and we will hope again. It is a light touching on lots of different things. So it's a lot of information that we're going to be going over. So again, please stop me or let me know if you would like me to clarify something a little bit more. One of the first things that we identify and go over with our patients who come in a variety stages of gestation is a lot of education, support, and advocating for themselves within their recovery and within their prenatal care. Some of our moms come in their first trimester, some of them come in 4 days before delivery. Some of our moms, this is their very first child ever. Some of our moms, this is their 7th child. So we try and take the educational approach that, hey, just because you have been pregnant before or haven't been pregnant before, but happen to be a woman, let's just cover all the bases and not assume that we know what's going to be happening. So one of the first things that we do is try and educate moms about when we may need to call the doctor. What is something that would be outside the norm? And then what are some things about being pregnant that, you know, are common and not necessarily things that that are necessary to go automatically to the hospital for. So within our pregnancy groups, we have been able to coordinate with local hospital nurses who work either directly in labor and delivery and or in the NICU with the babies once they've been delivered. So when they come, we've got a lot of almost show and tell. They bring a lot of the instruments and other items that are used during labor, during delivery, and then even afterwards for postpartum care, so that it really takes away a lot of the stigma and fear that the moms may feel as they go in for their triage appointment, as they're laboring, and through the whole process, so that they get the chance to, you know, hear the words and know what those words mean, so that they feel informed and educated to ask questions and make sure they are getting the best care that, you know, they want and can understand. So some of the things that we, encourage moms to do is to really pay attention to their bodies. We talk about round ligament pain, which would be that picture right there of the abdomen with the pain on the left-hand side, trying to normalize some of the things as much as possible, but always encouraging moms that if you're unsure, even if it's something that, your doctor said at your last prenatal appointment, that call just to make sure, even if you're concerned. As we go through the very first appointment that patients will have, just trying to give them some education, some information, so that if something happens or they have thousands of questions, they can get a little bit of reassurance during this time. We also want to make sure that moms are aware that, yes, this pregnancy, whichever number it is, and them as a mom are very individualized, very personalized, and very special and unique in that way. However, the practices and some of the things that they are going to experience are common and generalized for every mom. One of the things for our moms being in recovery is a large stigma and feeling of being attacked. So we want to normalize a lot of the things. Absolutely everybody gets drug screened when they come into a Cincinnati area hospital for triage or prenatal care. It really doesn't matter their background. So trying to conceptualize that for our patients can really bring down the level of fear and bring up the level of trust, thus hopefully encouraging them to continue with their prenatal care. As far as that second to last one, why can't my support person come back with me at first? That's changed a little bit since COVID. That initially is to screen to make sure that, if there's any domestic violence or safety concerns at home, that mom feels safe enough to share that information. But with COVID, that has changed a little bit up here, as I'm sure it has down there as well. So with being in recovery, drug testing is a very large part of that, to gather information and make sure that we are providing the best supportive care based on if any medication needs would be necessary. We always try to encourage and reiterate to mom that, one, since everybody is drug screened, the truth comes out anyway. It always gets found out. And we want to make sure that there are no surprises for mom and that she doesn't feel that the rug has been pulled out from under her, because these, unfortunately, we've seen can at times lead to, a distrust and thus, not going to as many prenatal appointments or not returning to their treatment provider for their substance abuse disorder. So just making sure that they are fully aware and have no surprise factors of the fact that they will get drug tested. And then once the baby is delivered, that the baby will also be drug tested. Here in Ohio, the baby will be tested from the umbilical cord. And in talking with the nurse educator in Kentucky, she said that at times the cord will be tested or the meconium, which is the baby's first poop, would be tested. As far as validity and how far back that goes for accuracy, I know that at least up here where we test the cord, it can test back as far as when mom was 16 weeks pregnant, so 4 months. But one of the really positive things about being able to do that, because it's really scary for mom to hear because maybe she didn't start seeking prenatal care for a while. One of the positive things, at least up here, is that upon confirmation of that cord test, the toxicologist is able to see if there is use present, when that use was, if it was at week 14 or if it was at week 40, which is definitely reassuring to mom. So part of what we try to do in educating mom and supports about the importance of getting prenatal care is answering some of those questions and debunking some of those myths for things. I have a lot of moms come in and tell me like, well, I haven't gotten prenatal care yet because I haven't gotten sober yet. Like, well, there's no rule that says that we have to do one and then the other in a linear fashion. It actually is a great thing to do them at the same time. It gives you a lot more support, and having that communication between providers allows for better care all around, honestly, better support, better care, and then better treatment for both mom and baby. So when patients come to BrightView first for care, one of the questions we ask on their very first day is if they're getting prenatal care, and if they're not, we coordinate to get them to that care and treatment from day one, should they want it. We can't force them, unfortunately, but it's always strongly encouraged. If they do or do not have prenatal care, we always encourage the collaboration, the hiding of secrets. Not only is that something that, you know, is a very natural part of being in recovery, having that fear, but it will have a better outcome if there are no secrets, if there are, you know, no barriers to be able to discuss the patient's best treatment for both mom and baby. So we encourage releases of information for all information both ways. So that way, if there's question or clarification, changes happen in medication, or changes happen in, you know, if mom has to be, you know, unfortunately, emergency for any needs, we can have that full support on both ends. Part of what we also talk about is, you know, medication. Here at BrightView, we offer a variety of medicated assisted treatment, including, you know, Sublocade shots, Subutex, Suboxone, and not everybody's treatment looks like everybody else's. It's very individualized. It has to be. So in order to do that, we meet the best patient's need based on what the medical director feels is most appropriate. And patients talk and they try and see, you know, well, this is working best for me and this is what I have going on. So we try and encourage patients to remember and being of the understanding that what works for one may not work for another. And this is, you know, without disclosing what one patient may be prescribed or what their treatment looks like, this is why yours is specific for you, and really making sure to focus on mom as a part of, you know, the core for why her treatment may look a certain way or may not look a certain way. The treatment is always kind of fluid and in flux, and never a rigid thing. We always want to make sure that we're doing and changing whatever we need to for best success of mom and healthiest baby. An unfortunate part that comes with recovery a lot of the time is the option for a relapse. So we take a lot of time throughout our groups and in individual counseling sessions to discuss relapse. Moms that feel a lot of shame, a lot of guilt with being in recovery and being pregnant. If relapse or even a lapse does occur, really processing, you know, what that means and the fear that they feel for, you know, having this disease, a disease that unfortunately takes away the choice of whether or not use is going to happen. I have more than one occasion heard a mom tell me, you know, if I could choose, I would of course choose to not use ever again, but that I don't have that choice, which is, you know, a classic factor of an uncontrollable disease that they have. So we really try to make sure that we do not take any form of punitive approach to our patients in any capacity. If a relapse happens, then we explore, you know, what was going on around. Was there a whole lot of stress? Did we not have enough contact with supports as needed? How can we identify those barriers and change them moving forward so that if we're in a similar situation in the future, we feel like we have more options for things. If it occurs, then we'll make changes again as necessary, making sure that mom feels as supported as she can during this time. One of mom's fears a lot of times that I hear in working with them over the years is, well, now that I use, people are going to think that I don't care about my baby, or the baby's automatically going to be from me. And it's a lot. There's never been a question of if you care about your baby or not. You're here, you showed back up. That's probably one of the hardest things to do for mom, is to have that courage to return to treatment and continue to ask for help after stumbling, knowing that there are potential consequences for it. So making sure that through those ROIs, we have that communication so we can discuss, hey, this is what happened and this is already our plan moving forward, so that we can have the best outcome, is really the crux of what having a supportive and open communication between providers and patient can be, regardless of the type of provider. What we do in pregnancy group is create a separate relapse prevention plan. We encourage all of our patients to have a very general relapse prevention plan of, should I be in a triggering situation, where can I go? How do I get there? Who can I call? Things of that nature. We make it one a little bit more specific and detailed in pregnancy group for being pregnant, since it does bring its own separate set of fun side effects. So we make sure that we identify what those are to the best of our abilities proactively, so that we can be as proactive as possible in connecting with those supports. Emotions and lots of other things run on overdrive while being pregnant. And I think it's, even for our veteran moms, it's surprising to them that it can still be just as intense, just as overwhelming. And even if I'm, great at juggling all of the other things, adding in this one additional factor can really throw things for a loop. And making sure that mom, one, feels supported and has a plan to take care of these things, but also, again, normalizing it for her that while she is a great example for her peers and for her children and for her family members, she's still just a mom who's pregnant, and it's okay to need help, and that it's okay to ask for that help. And it's not seen as a negative thing. It's actually seen as a very positive thing to recognize that help on any level is needed and reaching out for that.
Ashley, we have a question from Mercedes Helton. She was wondering how long it takes to get results back from umbilical cord testing.
That actually is a fantastic question that I don't 100% know the answer to. I would think it would probably vary by hospital. My understanding in working with the educators from the hospitals up here in the Cincinnati area is typically within 5 days. Here, and actually down at the UK hospital as well, moms are welcome to stay, but are typically discharged before the 5 days. Baby is automatically hospitalized and kept an open patient for 5 days to monitor for withdrawal symptoms. It kind of is going on the mindset of mimicking what adults go through in terms of withdrawal. If there is medication that is being taken, and depending on the substance, the medication, buprenorphine, stays and has a half-life of approximately 36 hours. So at about the 48-hour mark is typically when our adult patients would start to feel some withdrawal symptoms for that. And if you think about, you cut the umbilical cord from mom to baby, and they're no longer receiving any type of medication, then we want to make sure that baby is not being exposed and not being sent home experiencing any withdrawal. So while I don't know the direct answer, I do know that the results typically have come back during that 5-day time frame, but I would encourage you to contact whatever hospital is closest to you that you've been working with to get a more direct and specific answer for that. I was going to pause here anyway to see if there are more questions, so please, if there are, let me know. Okay.
I'm sorry. It took me a minute. It's Kira. I'm trying to get my video on.
That's okay.
I did have a couple of questions. So how do you mentioned relapse as part of the process, and I completely agree and understand that. What do you consider a relapse? So if one of the your clients in the program, a mom, is continually testing positive, how do you handle that situation?
We kind of take a cue from the patient. Some of our patients identify it as a full-blown relapse. Some of them just identify it as, a hiccup or a lapse. In terms of the actual verbiage of it, we don't put one more over the other. It really is just how we address and support the behavior to make sure that it's having the best outcome for things. So here at BrightView, what we would typically do is make sure that there are any additional resources that are needed. BrightView is an outpatient facility, and unfortunately, we're unable to support any higher level of care than about 4 times a week to be able to come for services. If that's needed and maybe a residential or an inpatient facility is needed, then we would definitely help refer and make that connection to get mom to that service just so that she can stabilize. And a lot of times that might be all that's needed. As far as any adjustments that would be potentially made to medications or dosages, I can't 100% talk to that. That is up to our medical director. They have, I know in the past, tried a couple of different things in terms of maybe mom has to come and pick up daily from our opioid treatment window and kind of dose here on site just to make sure that the medication is being absorbed properly. Sometimes they've had to increase dosages, just kind of like with everything else being pregnant. The more the pregnancy progresses, mom gets more tired, baby takes more energy, baby takes more calcium, baby takes more of mom's food, and she has to try and, supplement for that as much as possible. And it's very common a lot of times that, baby will take more of the medication for themselves to not feel sick and kind of mooch off mom, which we definitely want for healthy babies. But not having that full amount of medication for mom can leave kind of an opening for those triggers to come in. So our director has at times increased medication dosages as needed to make sure that mom is not feeling any kind of withdrawal, not feeling those triggers and those cravings any stronger than she really has to.
Great, thank you.
You're welcome. That was a great question. Yeah. Okay, so after addressing the importance of seeking out prenatal care and follow-up attending those prenatal care appointments at whatever rate that the prenatal care provider decides upon, we then move into what you can expect when you're actually going to go into labor and delivery. We walk mom through the whole process of what is going to happen. We try and take down any of the curtain at Wizard of Oz and totally reveal what's going to go on behind there so that they are not feeling confused, not feeling frustrated or caught off guard, and definitely still have that feeling and sense of control and that ability to advocate for themselves for whatever they need. So making sure that they're aware, they're going to take a full history, they're going to do a full physical, trying to normalize a lot of the things. And as the facilitator for the group a lot of time, and I've also been a mom, they would ask me like, is this true? They really do these things? And I'm like, well, yeah, it's just a standard procedure thing. It's, you're very special in having, being your own unique person and having this experience. However, a lot of these things you're not special, and they just have to make sure that they do them for everybody. So that actually decreases a lot of the frustration that they have when the nurse educator is saying, hey, when I have to put an IV in you, it's not trying to be rude. It's not trying to be crude. I really just want to save you any kind of discomfort. So when I ask you, where am I going to get you in terms of getting your vein, please don't be offended. I don't want to stick you more than one time. And if you're going to tell me it's not going to happen, then we will call I think it's called circulatory, something to where like the IV specialist comes in and they almost have this machine that can, see an x-ray through to find the most effective vein. And moms are like, I always wondered why they asked me that. So it really does answer a lot of questions that a lot of times they'd be either too afraid to ask or feel that they never had the right forum to. So it's a very open, realistic conversation that is had throughout this education, which ends up having a really positive outcome once they come back to new moms group and share the information that they've been given based on what happened. They're like, they said this would happen in XYZ order, and it happened in XYZ order. So it's been really reaffirming to them. Some of the things that they're very concerned about is, what about epidurals? When am I allowed to do that? Something that I learned from our nurse educator up here is that varies kind of by the doctor. I've heard that it can be, up until, whenever you want to do it until the baby's about to come out. I've heard some say, you have to wait until you're 4 centimeters. I've heard some say you can get it as soon as you want. So we always encourage mom to just ask her prenatal care provider what their practice is so that she can plan accordingly. If mom decides that she wants to do it, covered wagon style and do that, we try and learn that information as soon as possible, because preparing for an all-natural birth is definitely different than preparing for any kind of assistance in terms of epidurals, spinals, things of that nature. When it does come time for things and discussing about monitoring, the nurse educator will bring out the monitor. She's got the band that goes around mom's belly, and she passes it around so they can see how it stretches. And she even will bring the internal monitor that is used on baby, that kind of gets screwed into baby's head. And then she's like, look, this is what it is, trying to make sure that, everybody envisions this huge wine corkscrew going into baby's head for internal monitoring. She goes, no, it's this, don't worry. And then she, will demonstrate as much as appropriate, about how it's guided in and what it's used for and when it's used, that it's not always a common practice and things of that nature. We'll also, as we're talking about different types of childbirth, again, I think this is a little bit more provider specific and of course mom specific in terms of vaginals, cesareans, if they're going to have, a VBAC, and if, previous C-sections would allow for vaginal afterwards. I'm sure there are at times, underlying pre-existing health conditions that may or may not exclude certain forms of delivery. All of those things we encourage mom to have an ongoing conversation with her provider about. One of my favorite things about how BrightView's pregnancy group goes is that it is on a continuously rotating 8-week cycle. So if a mom comes in and she is newly pregnant and it's her first time and she comes in on week 6, she's like, oh my gosh, I missed the information that I'm going to need. And we're like, nope, you're fine, because in 3 weeks we're going to get to that part that you need. So as long as mom is in, she'll get the information, a lot of times several times. And when we were developing this and people were asking, isn't that going to be kind of old for mom? And I'm like, well, at some point it will be relevant once, if not twice, being that, a trimester is 3 months. Well, she'll get all of the information at least 3 times then. I'm sure when she first comes in, it's very overwhelming. She probably didn't really hear it or remember it the first time. So the second time is a great kind of recap. And then the third time, she can actually give a lot of great feedback to, the new patients that have come in and share some of that. And again, reduce any stigma that may be there and qualm any fears that may be there from a peer standpoint. So it's actually been a very, very beneficial thing. And that's the feedback that we've gotten. So in terms of how many people that they can be there, here at least, and down in at UK as well, the educator told me it's 1 person in the hospital, and that's the same as here. And it actually, especially now since COVID, has to be, the same person for the entire time. They encourage them, like, if they need to leave and go take care of other kids, to not do so a lot if possible, return quickly if possible. But it's not any more for a time it was like one person each day, but it was that same person consistently each day. And now I believe it's adjusted to just be one person. And we haven't updated our information for the specific COVID things. I think we're all kind of praying that it's going to go back to the standard norm that we're used to. So we're just verbally sharing with patients any kind of impromptu changes that have occurred, knowing that each hospital might be a little bit different and each visit might be a little bit different. So down in Kentucky, the educator told me that they do use which one is it? They do use Stadol for comfort down there. She did not mention anything about Nubane. That's a very nice, consistent thing. Kangaroo Care is a skin to skin. I honestly can't remember, Nikki, what you said. I had been able to share with Nikki some handouts, some patient-facing education about Kangaroo Care, skin to skin care, things of that nature that I'm thinking, if I remember correctly, got sent out to everybody, but just reinforcing for mom that, if anything, happens, regardless, she is probably one of the best treatments for baby. One of the practices that was changed up here just in the last couple of years is for the first full hour after mom delivers, baby stays right up on her chest, skin to skin. And they've noticed that, that has decreased any kind of, immediate potential health needs and really increased the calmness factor for baby to have that. So for the Kangaroo Care, and then we open this time up for, a lot of questions for things. We encourage a lot of things that, they're already used to in case baby does start showing signs of discomfort or withdrawal symptoms. Talk low, keep the lights down low, don't have a lot of people in. We encourage, breastfeeding for moms, and so long as that there are no substances that have recently been used. All of those things are hugely beneficial for baby overall health, as well as if baby is showing any signs of withdrawal symptoms. We talked a little bit and touched a little bit more earlier about the infant drug screening. I don't think they do the cotton balls as much. When the nurse educator described to me how she did it, was a little funny, because apparently they will put the cotton balls in the diaper and then collect the cotton balls, put them in a syringe and try and squeeze the urine out, which just seemed really cute. But they found it just was not as accurate as the cord or the meconium. Which is just another confirmatory for and support for the information we've been giving to mom of, please be honest about everything that you've used and when you've used it, because it's going to come out. And we try to make sure that mom knows that that's not any kind of judgment. It's not any kind of threat. It's just a fact. Everybody gets tested, baby gets tested, regardless of any kind of past history. And as long as what you're telling us is lining up, that definitely has a better outcome than if there are secrets, if there have been lies, if things are trying to be hidden. And sometimes mom says, I just don't know. I don't remember. And I'm like, that's fine. Just be honest about it. If you don't know, you don't remember, you can't make it up. Don't lie. Just say, I honestly, don't remember. And then whatever the outcome is, we will figure it out. That's what some of our favorite things to do, since once you become pregnant, you're not really in charge of a whole lot anymore. And then once the baby comes out, you're not really in charge of a whole lot anymore. So we just kind of figure it out. We figure it out every single day in recovery and in treatment, how to make sure that we have the best possible outcome and the healthiest possible day. And a lot of the principles apply once we have a baby as well. You just figure it out every single day, how to get through the day with everybody being as happy as they can be, as healthy as they can be, and ideally sober as well. So one of the positive things that the educator down in Kentucky shared with me is that they also encourage breastfeeding simultaneous with taking any MAT, which is also what is encouraged up here. Reason being is mom is always very concerned that there's going to be so much medication that is passed through their breast milk. And they're like, well, what about if I decide to stop breastfeeding and I don't want my baby to, withdraw off that? And the way that I explain it to them is, if you've ever had a migraine and you have, specific migraine medication, and I've never had a migraine, they sound honestly terrible. But if you ever had a migraine, you have specific migraine medication to take, take that burden away, but you're out of your migraine medication. So you take something like, Advil or Aleve or some other thing that, is not my specific migraine medication, and it does not make the migraine go away, but it does take the edge off just a little bit to where, you might be able to fall asleep, or, the fact that your lights are out and you're laying down is something that you're aware of. And that's kind of how much medication that baby is going to receive through breast milk. It's not going to take away any signs of withdrawal completely. It's not going to be enough to the point where if you decide to stop breastfeeding, baby's going to have this really negative reaction. It's just enough to take the edge off for baby, that they can realize, oh, I'm skin to skin on mom. I know her, the lights are down real low. I can feel her heartbeat. I can smell her. I'm swaddled up real tight. All of these other non-pharmacological supports for baby are happening, that if they are unable to be aware of their current surroundings as much as they can, aren't going to have the effect. So with the breastfeeding, aside from just the strong benefits of breast milk for a baby's overall health, it takes the edge off the amount of medication they would get through the breast milk, so that they can be aware of these other things, so that they can hopefully not need to have any kind of outside medicated treatment to help with any withdrawal symptoms. Again, we encourage mom, as long as you're only taking medications that are prescribed to you, then yes, please breastfeed. If there's any substances in there, please don't breastfeed. If you're taking medications that are not prescribed to you, please don't breastfeed. If your plan is to breastfeed and you're just waiting for, things to clear out of your system, pump and dump. We connect them with our case management team, either through BrightView, or we encourage them to contact the case manager or social worker through the local hospital, because a lot of the times their insurance will cover a breast pump. And at least up here, they can rent one, a hospital grade breast pump until theirs comes in, which apparently are like magic and can pull something out of nothing. And that way they'd be able to have that for later on. Some of our moms decide that they don't want to breastfeed, which is absolutely fine. Then we also connect mom with our case management team to get them set up for WIC and figure out what kind of formula would be covered by WIC. There was a lot about that one. I want to make sure that there's no questions about that, because this is always a lot of strong questions from mom about this part. Okay, perfect. So we try and encourage mom to have a little bit of planning and forward thinking for when she and the baby do come home from the hospital. So when we talk at a group with moms about, let's have a safety plan, their mind automatically goes to a child protective services safety plan, and they get very agitated about it. We're like, no, we're not going anywhere about that. Let's have, a safety plan for you of, something's happening, I need help, the baby, won't stop crying, the baby won't eat, the baby just won't sleep, not even anything in terms of colic or croup, just regular baby stuff. What is the plan for that? So something that our moms have actually gotten into a routine of doing is, in one of the groups at the very end, they almost make a calendar, because everybody wants to come see, even through COVID, everybody wants to come see the new baby and hold the baby, and that's great. And they're like, I don't want to be host at that time. And nor should they. So we really encourage moms to, advocate for themselves and taking control of this time. Of course, they want to show off their new baby. However, why not, tie something to it? A lot of times people that are coming are family members or people who are supportive of you. What would it look like if you asked them, hey, yeah, when you come over on Tuesday, can you do a load of laundry for me while you're here? Because you're not supposed to be doing really a whole lot of things for the first 6 weeks. You want to come over on Friday night? That sounds awesome. Could you, stop at McDonald's and bring me dinner as well? So almost making a calendar. One of my moms actually went so far as for the first 3 weeks, she had sign up times so that she didn't have 6 people coming at one time, so that she wasn't overwhelmed and her baby wasn't overwhelmed, but that she also had consistent support. And that was the main factor for it, is not that she was concerned or afraid or anything to be alone with the baby, but lots of still things. She's like, the rest of my life can't stop. I have other kids. I have a house, that needs to have things happen. And I just can't do it all. So this is what I came up with. And she said that it actually worked out really, really well. So I actually kept her template and I share it during group with some of the other moms, be like, this is not out of the realms of possibilities. Absolutely. Take control of this time and see how much help you can really get, because there's nothing wrong with any of that. If you guys were able to get the handouts that I had shared with Nikki, one of them on a whole front page of it is the purple crying period, which was something I honestly wasn't aware of until one of our case managers said, like, I didn't know what it was either. My new daughter was doing crazy stuff. And so I just went to Google, and she's like, and I found this, and it's a real thing. So it gives lots of information and lots of education about what the purple crying period is. And things that you can do to honestly just survive it, because my understanding is it's somewhat a little bit like colic. You can't do a whole lot for it other than try and relieve a little bit of the symptoms, and then honestly just kind of wait for it to go away. A lot of the things that we try and encourage with mom is that she's not doing anything wrong. She's not missing anything. This is just something, like, she likely could not have avoided this. It's just something that is unfortunately something that her baby, has right now. And this is the plan. This is what you can do to help support your baby, to feel, a little bit more sane, and just changing some of those self-care practices. In recovery, that's one of our biggest things, is personal self-care for success, whether that looks like boundaries, whether that looks like, deep breathing, meditation every day, whatever that is for mom as a patient in recovery, not being mom, trying to see and find time for that. Becoming a mom, a lot of the times the personal self-care, like, your needs go to the bottom of the list, and we try and, normalize that. Like, let's start slow. Like, don't be surprised if, because they go to very large things, like, oh, I'm not going to be able to, go to my meetings, and I'm not going to be able to do these things. We're like, let's just make sure, that each day you eat something, ideally something healthy. And let's make sure at least, let's go with twice a week, you're able to take a shower. So those really basic self-care things, so that mom can feel, like a person, for some of that. And that's where we encourage them to use their supports and speak up with that plan. On the other side of that, that card that we were able to share with you guys, hopefully we give it to patients, is things like safe sleep, and how to do that. We also strongly talk about the 5 S's, which is also covered down at UK, which is great. So the 5 S's are something that were developed of, seems Harvey, and honestly his last name's escaping me, I apologize, I can look that up, and to help soothe babies, again, non-pharmacologically. So the 5 S's, let's see if I can remember, are shushing, so almost making a white sound noise louder than what baby is crying at, so that they can hear you. Kind of this swaddle factor, so wrapping up real tight into a cocoon. It helps baby feel as though they are still in mom's womb. This kind of jiggly, or it's called shaking. It's not shaking. He goes strongly into this. It's this real light kind of back and forth, almost like if you oh, have one of those like bouncy chairs for baby that kind of like does that vibrating thing. It's this real gentle kind of motion to try and mimic that swaying of being in mom's tummy. Sleep is another one of the S's, and sucking. So either thumb sucking, latching, and maybe not necessarily nursing from mom's breast or through use of a pacifier are all things that we try and encourage for mom to do and practice ongoing, even if there is no withdrawal, no purple crying period. Just like, these are things that you could do that can help create a calming environment for your baby. One of the things that we do encourage and educate moms about is SIDS. So risk factors, safety factors. At the hospitals up here, they will use the sleep sacks for baby and wrap them up. And those, the educator down at UK said that they have these specific kind of, nursing bassinet things that do all of the 5 S's for you, which sounded really nice. But making sure that mom knows, it's going to be rough. Sometimes the only place baby will sleep is on your chest, but as tempting as that can sound at 3 a.m., we always have to make sure that we are doing the safest thing for baby, so that nothing negative can happen. Accidents, they can happen, but let's be as proactive we can to be as accident free as we can. We do talk about, smoking. We encourage smoking cessation. Our providers at BrightView can write prescriptions for NRT, the patch and the gum. We encourage things like that to use. We always have to kind of do a backup plan. If mom is like, nope, I just can't, quit smoking. We're like, okay, if you can't quit smoking, then do all the things that you can to protect baby as much as you can from that smoke. So, of course, go outside. If you're going to really go there, we're like, there's kind of, I guess, levels of what you're willing to do. If you're going to go outside and smoke, then really what you should be doing is taking a full shower, washing your hair, washing your hands real good, and putting on fresh clothes each time. If you're like, well, I don't have time to do that, okay, well then maybe at least change your shirt, wash your hands, of course, real good, and try and find things to reduce any of that potential exposure to baby. We also try and encourage moms, a lot of these new baby things, they're very cute, but they're not really going to be very useful or necessary for an infant. So all that huge crib, display with all of the stuffed animals and the big quilts and the quilt, or the bar protectors on the crib rails, like that's, a very beautiful setup. The baby really needs to be in the sleep sack alone in the crib and like nothing else. So it's going to look kind of bare, but that's what's safest for baby. No, they won't be cold. They're not going to be bored. They're just sleeping. So making sure that we can encourage that as much as possible. And they're usually pretty open to that. Up here, we have a lot of resources following the hospital for once mom is discharged from the hospital. A lot of our hospitals will have a home health aide visit and schedule that to come in. We encourage moms to use any kind of feedback and support that is available to them. We have a program up here called Help Me Grow that will follow mom and baby, I believe, for the first year to have some ongoing education, answer any questions or concerns for anything, and have that option. Down in the UK, Kentucky area, the nurse educator told me that they have places called Pathways and Beyond Birth that they refer to for support. So it's nice that there are additional resources just real close for things.
Ashley, we had a question Do you recommend all the precautions if parents smoke and have older children?
Oh, we have smoking cessation regardless as a part of treatment at BrightView. For that, it's a diagnosis just like opioid use disorder. If they smoke, they're diagnosed with tobacco use disorder as well. So yes, that's always encouraged. For some reason, I've noticed over the years, moms look at the new baby differently than their other kids. I'm not exactly sure why about that, but we try and touch on it a little bit more directly within pregnancy group for that. Since their focus right now for that group is the baby, we try and use that kind of medium, but smoking cessation for that is ongoing throughout treatment, at least with BrightView. Are there other questions at this point? We're a little bit, oh man, this is good. We're a little bit about halfway through the slides and we're about halfway through the time. So that's working out nicely.
I just wanted to add that for our advocates that Kentucky has the HANDS program. So I think it's like something help in accessing nutrient, I don't know, but they work with families. Any family in Kentucky is eligible who has a new baby, and they work with families for the first 2 years of the baby's life. So it's a really great resource for new parents.
That's awesome. Kara, just for my own curiosity, is that available with each new baby or is it just for very first time moms?
Oh, that's a really great question. I don't know.
Sorry to put you on the spot.
Pop up. I'm trying to think of the most recent one I had was not a first time mom, but it was the only child the mom had in her care at the time.
I think it's any child, and it stands for Health Access Nurturing Development Services. It's through the cabinet, but I think it's any child.
Okay, great. Thanks, Liz.
Mm-hmm. That's awesome that you guys have that. So exciting for you for that one and for your moms. So moving through, we are getting to, with moms to start thinking about, all right, you're going to start getting discharged from the hospital. Let's start looking a little bit into the future. We strongly encourage, scheduling and making that 6 weeks follow-up appointment and following what the doctor says, even if there is a magically perfect labor and delivery and that was, went as planned with vaginal delivery and let's say there was no tearing or no need for an episiotomy, perfect deliveries that occur. You still have a very large wound. You still went through a major procedure of delivering a child. And that apparently is also not the common thing to have the perfect labor and delivery process. Usually some form of support is needed, whether that be tearing, episiotomy. I don't know if like forceps and vacuums are still a thing, but like usually something occurs, even to a small degree. Let your body heal for things of that nature. Our nurse educator brings in a dinner plate and she just holds it up and she's like, this is the size of the wound inside of your uterus. Let it heal before anything happens. And she talks to them and educates them about, blood clots. And if bleeding increases, that means you're doing too many things. She's like, just try to do as like little nothing as you can. And we have very realistic conversations again about using the supports while you can. We have a whole class dedicated towards the different types of birth controls just are available, whether that be the Depo-Provera shot, a variety of types of pills, the Nexplanon, like the implant, or the IUDs, like whatever it is that, if they're wanting birth control, talk to their provider and be like, hey, I think I'm interested in birth control. What are my options? When can I start things of that nature? One of the things that we do try very, very hard to tell our patients is that breastfeeding is not birth control. If they do decide to breastfeed or pump, yes, that is going to delay the period from starting. That does not mean that they are not ovulating. So then we have some, women's health education about what that means. And yes, a lot of the times those two things are tied together. However, not always, and especially not when you're postpartum. And that actually clicks a lot of things for moms. They're like, actually, that actually makes a lot of sense, because I wasn't having my period while I was actively using, yet I got pregnant and now I'm here. And we're like, oh, your body's an amazing thing. Why don't we listen to it, let it heal, and then be proactive for things like that. Probably some of the, I'm going to say the word hardest, just because looking at my mom's faces when we go through the NAS classes, it's just hard for them to know that this is a possibility for their patients, and that's for their babies. And that's something that we really try to reiterate, is that, just because your baby was exposed to a medication or a substance, that does not guarantee that withdrawal will occur for a baby. It's an option, but it may not happen. And that's something that is very, confusing and frustrating for moms, and for honestly, sometimes outside providers and for family members, is that, first of all, there is no way to know while mom is still pregnant if her baby will experience any withdrawal symptoms. There's no test that can be done. There's nothing that can identify that, baby A is going to experience withdrawal and baby B is going to not experience withdrawal. The only thing that we can do, and that we encourage mom to do, is to not use, take whatever medication she's prescribed as prescribed, and just follow her treatment plan, usually with us, with BrightView, and follow the care that her prenatal care provider is encouraging her to do. I've had moms be like, well, going back to the medication part of it, of if baby takes more and mom starts to feel withdrawal symptoms, thus potentially increasing the possibility of illicit substance use, she goes, I don't want to go up because then my baby's going to withdraw harder. I'm like, that's not actually how it works. It's not a one-to-one. So what we try and convey to mom is, if you as mom feel withdrawal symptoms, that means that your baby's taking more of your medication because they were starting to feel withdrawal symptoms. So just like for you as an adult, if you weren't pregnant, if you are feeling withdrawal symptoms and you're taking your medication the exact way that you're supposed to, you tell the medical director here at BrightView, and they say, you might need more medication to not feel withdrawal symptoms. So more medication doesn't equal higher withdrawal. It actually decreases the withdrawal, which is what we want. So it's hard for mom to make that connection. And they're like, yeah, but if I'm on this amount, then this increases the chances. And I'm like, again, no. I've been working with pregnant moms in recovery for 7 years. I've worked with moms that are on buprenorphine products. I've worked with moms that are on methadone. I've had moms that are prescribed what would be considered a higher dose of either, and baby has 0 withdrawal symptoms. I've had moms that are prescribed what is considered a lower dose of either, and baby has withdrawal symptoms and ends up needing to be medically treated. There's no way to know. Baby is going to be the one to decide after they come out. And explaining it to them, honestly, multiple times, because that's a really, really strong fear. They don't want their baby to suffer. They feel very, very guilty about, the fact that this is the situation that they are in, and that this person that they already love and care about so much has to have the possibility to suffer. And they know what that withdrawal feels like. And they know for themselves how helpless they feel, which is where, a lot of this comes in for them, which is where we come in and continue to give the support of, but you're not helpless here. There are things that you can do to help baby feel better. Swaddle, keep the lights low, stay skin to skin on you. It's amazing the skin to skin and what that can do for baby and their symptoms. If you are going to breastfeed, like doing all of these things can help decrease as much as you can the uncomfort that baby is feeling. Sometimes those things are enough, and sometimes they're not. And medication is necessary for baby. But again, there's no way to know any of that until baby comes out. This is a very angry picture of a baby that is a kind of a reiteration and going back over some of the information that we discussed with mom earlier in earlier classes with them. So one of the things that we try and educate moms about is that their babies aren't born addicted to substances. They are exposed to substances. Part of an addiction is the behaviors associated with the substance use, which the babies don't have. So they are exposed to illicit substance use, or even sometimes prescribed opiate substance use or other prescribed medication use, but they aren't born addicted for things. Just because they're exposed does give that option of experiencing NAS or withdrawal. But again, always making sure that mom feels empowered of this is, if this is an option, this is what I can do. A lot of what, recovery is being aware and mindful of where I'm at currently, somewhat being proactive and kind of anticipating the very, very near future and making a plan for that so that, I'm not caught off guard for anything. If I am caught off guard, I know what to do. I know the next step to take. I know the right person to call, and I've got a plan about what I'm able to do. A lot of the things for babies who are born exposed and babies that are not born exposed and mom has zero history of substance use is, they mimic a lot of the same things. They're going to cry kind of just because. They're going to cry a lot. They're going to, they're going to cluster feed, and it's going to be, very almost, common feeling for them if they've had other babies. They're like, oh, well, my other child did this and didn't have anything. Like, see, you've been a mom, you know how to do these things. It's just like getting back on the bike. And for our new moms, it's, giving that extra education of like, you just kind of do whatever it is that the baby needs to do. You're learning just as your baby is. And that's one of the great things of how that bond is built of they don't 100% know what they need. You don't 100% know what they need. So you both kind of troubleshoot and figure it out together. And that's where that trust in mom from baby comes. And that's where mom starts to trust herself and her abilities, which is a really strong, positive ongoing factor of a strength for some optimism for the future for her. I'll do a pause here again to see if I'm pausing about every 5 slides or so, hopefully, to see if anybody has questions about anything that we've gone over, if they'd like me to clarify anything. I'm also roasting in my office, so I need to turn my heater off real fast. Okay. So one of the handouts that I hope was able to be shared is a Finnegan score. I'm pretty sure that the Finnegan scores are the same at most hospitals. The one that I was given was from one of our local hospitals, and it's directly what the nurses use to score babies. So Finnegan scoring is going through a specific set of symptoms, behaviors, things that baby is exhibiting for those 5 days that that they are, that they're here, those first 5 days. They don't score typically the first day. They usually start around that 36 to 48 hour time frame. and they are scored while they're in the hospital by the nurses every 3 to 4 hours. This was something I was really encouraged in talking with the educator at UK about, is that this practice here, down there is the same. The nurse will come in and score the baby based on this criteria every 3 to 4 hours. If there are 3 consecutive scores over 8, or 2 consecutive scores over 12, getting that 24 number, then medication is then usually recommended and started. Up here, the hospitals use methadone, and the educator down at UK told me that down there is used morphine. The same practice is used though. It's a taper process, typically about 2 weeks in terms of the time frame of how long it takes. And it's usually the amount or dosage is based on baby's weight. I don't know a whole lot more about the medication part of it from that part. I do know that it's not a linear process. So up here with methadone, it is kind of like an 8-step process, and you can be on step 3 for 4 days. You can go from step 3 to step 4 and then have to go back up to step 3. So it's kind of a fluid thing, always based on what the baby needs. We encourage moms to test, do the Finnegan scoring, even when the nurses aren't there. We encourage them to, advocate for themselves and for their babies. There can be this kind of desire to, make babies appear, healthier than they may be. I don't want my baby to have to be, treated, is what they call it up here. I don't want my baby to have to be treated. I completely understand that. However, you also don't want to take home a baby that is sick and you are ill-equipped to care for because you don't have the medication there. So if, every 3 to 4 hours when the nurse comes in, she scores the baby and the baby scores high, well, first of all, at least up here, I'm not sure of the exact practice down here, the nurse educator told me, she's like, I don't know why, but she's like, we pick terrible times to test. If it's going to be, for some reason, it's like right before feeding, it is right before a nap is supposed to happen. So your baby's already like the angriest they're going to be in terms of their own cycle for stuff. And here we are, and we're going to poke them, and we're going to lift them up, and we're going to see their head lag, and we're going to, make them cold and take the diaper off and all of these things. So they're automatically almost scoring a little bit higher. So we're like, you're the one with your baby 24/7. That's one of the strong benefits that both Kentucky and Ohio, the hospital, share, is once mom's discharged, she doesn't have to leave. Here at the local hospitals and down there, mom is welcome to, as a non-patient, stay with the baby for those 5 days. Up here at one of our local hospitals, Bethesda North, they've got an entire separate wing that they call the Bethesda North Inn with 2 ends that have private rooms for mom and baby, because that's best for the baby, honestly. So we encourage them to be like, score your baby, not every 10 minutes, but, score your baby once an hour, score your baby every 45 minutes, and keep track of those. Because if when you score the baby is either not scoring at all or scoring very low, and then when the nurse comes in every 3 hours, when baby's already mad and she scores them higher, you have this history of like, look, this is what I found, and you're finding this. There's absolutely, baby, at least here in Ohio hospitals, does not have to be taken out of the room for the scoring to happen. Ask to watch what the scoring is. Maybe the nurse is looking for something, a different way for a certain symptom than what you're looking for. And we go through each one of them so they know what to look for. So they know to look for, what modeling is. It's not like modeling clay that you can, Gumby your baby's arm. It's this kind of honeycomb looking feature. We encourage them and teach them like, look, this is what, the head lag is of when the head falls back versus staying upright. There's actually, in one of the classes that we show, there is a video that one of the hospitals took for their education purposes of a baby experiencing having some NAS symptoms, and they're, you know, narrating, going through like, this is the, you know, the type of crying that they're looking at. This is how the head leg is. This is the level of this. So that way, it was a little bit of a barrier remover from mom, because when we say like the baby's going to cry a lot, they're like, oh, okay. And it's a different kind of cry with this withdrawal cry. So them being able to hear that and, you know, see, you know, the baby having some of these, was the goal was not to scare. The goal is to educate. And we always, you know, prep mom beforehand, usually even the week before, like, now remember, next week we're going to show the baby video. Let's all be ready for this. And then we don't get right back into the education right afterwards. Once this, you know, 2-minute video is over, we stop for a minute and make sure, you know, mom's okay. That can be very intense. It can be, you know, very triggering. We take a break. We do some deep breathing if we need to. And then we always bring it back with, but this is what you can do. Here's the plan of how you can support. You want to be, you know, always the honesty about it, because if what you're seeing when you score and what the nurse sees when they score, if it's the same thing and medication's needed, just remember that means that's the healthiest thing for your baby. I had a mom ask me one time, like, well, what if I say no and, like, you know, they don't medicate the baby, what's going to happen? And I honestly can't remember what my nurse educator said, but I do remember we talked about it, and I'm like, their bodies aren't built to be able to handle that the way that an adult is. And I honestly don't know at either set of hospitals if, you know, mom gets to say no, or if the hospital and the provider and the doctor, you know, makes that decision for their patient. I don't know that. I would encourage you to reach out to your local hospital to see what their best practice is for that. As we, you know, move through the education and the information about NAS with mom, we always bring out the other side of the, you know, the non-pharmacological things that they can do, that they have control over, in order to protect baby and make sure that, you know, baby has as comfortable an environment as they can. So it's things, and we try and tie it to things that are, you know, not uncommon when they as adults are experiencing, you know, feeling illness or feeling withdrawal symptoms. Keep everything very, very low. Keep the lights low, keep, you know, sound low, limit the number of people coming in, limit the number of people that, you know, you're passing baby around to. Everybody's very excited to see baby. We understand that, but right now all baby really needs is mom. I don't want to leave any support person out of it, but a skin to skin with anybody is, of course, better than nothing. But I remember a few years ago, I had a mom whose baby was, you know, not scoring super high. They were scoring, you know, 5, 6, things of that nature. And I worked at a residential facility at the time, and she came home for the night, and we got a call that, like, hey, the baby score spiked a little bit. Can mom come back up? So she did. And within 30 minutes of just putting baby right back on her chest, the scores dropped right back down. So it really is an empowering thing for mom to know that, you know, she does have an effect for things, and it's an immediate effect just by being her and that bond that she's developed with baby while being pregnant and for carrying. Like I said, the tri-state area hospitals up here use methadone. Down there, they said that they use morphine. One of the things that is similar is that it's a possibility, and I don't know the details that would include, you know, offering it versus not offering it, but I've heard it at hospitals up here, and the nurse educator down at UK said that it's also, a possibility down there that once baby is discharged from the hospital, they potentially could get discharged with a medication called phenobarbital. I don't honestly know what that is. I know that I've had moms be discharged from the hospital with that prescription for baby. My assumption is that it's, just something kind of ongoing to make sure that, care and support and, any like maybe rise in things has something available for it. But that is something that is a possibility to be sent home with. Again, sometimes it typically takes about 2 weeks that baby would be in this step down, weaning down process from the medication used. And it's hard a lot of the times for mom. She usually, when I have moms that have babies that are in need of being treated, they want to live at the hospital, but then they realize, I have all of these responsibilities and all these other obligations that are pulling me in these areas. And they really wish they could be in 2 places at once, whether that be, other obligations in terms of family and children, some, coming back to treatment. Here at BrightView, we offer like a maternity leave almost from services. We do want them to come in and see our medical provider within a couple of days of them being discharged, just to have that, medical follow-up part and see if there's any adjustment to medication that may need to happen. But we offer, maternity leave from other services for a couple of weeks, depending on the type of delivery. And if mom doesn't want to do that, she's like, but I can't, I can't come in. We offer virtual and telehealth services for group appointments, individual appointments, and medical appointments as well. But it's hard for mom to leave baby at the hospital at all, even if it's just to go home and take a shower and take a nap and send other kids off to school, and she's gone for a total of an hour and a half. It's really difficult. So we really encourage mom to, always, use her supports. And if they don't want baby to be left alone, but they can't be there, see if another support is available, whether that be, a partner, a family member, anything like that. I don't know what the rules are now for that with COVID, but always asking what your options are. I'm like, if you don't ask, then the answer is always no. If you ask, the answer only might be no. And if the answer is no, see, okay, well then what options do I have for things of that nature? So this is always, we spend a little bit more time on the Finnegan scoring. If you're able to see the handout, it's very, very long and intensive for things. It is, some of it is very, I guess, almost minor in terms of like, sneezing. And a lot of my moms get very frustrated. They're like, all babies sneeze. And now baby's getting, they say they're getting dinged for just doing a normal baby thing. And I'm like, well, yes and no. It's not a sneeze. It's like 6 sneezes in a row of things of that nature. It's the intensity and the level of acuity that these things are. They're like, oh, babies cry. I'm like, yeah, but I understand your point and your perspective for things, but especially with somebody as new and delicate as an infant, more precaution is usually taken for things of that nature, for things like that. And once baby is discharged from the hospital and sent home, we always encourage mom, like, just because they complete all of this and that's fantastic and they, they're doing great, just, be aware and be monitoring of, your baby for things to potentially resurface. In 7 years, I've yet to have withdrawal symptoms resurface after baby's been discharged from the hospital. I think that's something that, is a recommendation of best practice from the hospital, just in case, because I'm sure it has happened. That's why they have that recommendation. And we always encourage mom that if you notice anything or have questions about anything, or it just seems, you can't even put your finger on it, but it just seems off, then to call their doctor and ask for guidance about what to do for things. So now that mom is home with baby and in as much control as she can be with a newborn, we start talking about feeding and some of that day-to-day care for baby. We talked earlier about the encouragement of breastfeeding for lots of things. Honestly, one of the things that ends up being the biggest support for mom that I've noticed over the years for breastfeeding is that breastfeeding is free, and it automatically, like, your baby, like that milk is made specifically for your baby. And the nurse educator, she's like, it literally is liquid gold. She said some of the formulas nowadays, they're really, really close, and they've, probably done as best as science can do to make it, but it's still not straight from the source. So we encourage breastfeeding, like, it's free. There's no guarantee that your baby will like the 8 million types of formula that are out there. It has all of these additional benefits for it. We try to encourage mom to at least breastfeed for the colostrum phase, the very, very first phase of that. And if she doesn't want to breastfeed at all, or if she has problems and, milk never comes in or baby doesn't latch, we try and connect her with the right resources. I've been able to make a lot of great contacts up here through the hospitals and bring in, when we have the breastfeeding class, bring in one of the lactation consultants from the local hospitals to answer some of those questions and to be like, that direct resource. Sometimes just bringing in a real life person as opposed to talking about that person abstractly kind of solidifies for the patient, like, oh, so when I call, you're actually the person that I'm going to be talking to. I can even ask directly for you and reference myself as a patient from BrightView if I want to make that connection for things. So it gives them a lot of reassurance and a lot of encouragement to use the resources. Lots of our moms are aware of the resources and maybe have tried with varying outcomes, but validating that frustration from the past and, encouraging and trying to break down any barriers that we can, even if that's something as simple as an introduction, has really proven to be helpful and beneficial. So if mom decides to not breastfeed and move to formula, we will try and do our best to connect them with a social worker, case manager here at BrightView to get ready and get applied for WIC or figure out if a prescription for the formula is needed. Recently, I'm not 100% sure, but I know for a while at least, WIC up here was only covering, I think, like the Gerber type of formula. And my mom was very, very frustrated. She goes, they don't like that formula, or they need this specific kind of sensitive or whatever, and that's not covered. And formula is really expensive. And I'm like, correct. So identifying those barriers and doing what we can to reduce those for mom. It's a lot of, going back to the very, very beginning of, let's sign this release of information and contact whoever we need to contact. I feel very proud, but also kind of strange about the fact that on more than one occasion, and I'm more than happy to do so, my voice at times is louder than my patients for my own patients' care for things. I had several moms who have spoken to, all the correct people, said the correct thing, had the correct request, advocated for herself as much as she can. She's like, I just can't get an answer for things. Will you try? And I'm more than happy to step in and advocate for my patients and whatever it is that they need. And they're like, why? Why do they just need to hear it from you and not from me? I said, honestly, I don't know, because, it's not my doctor, it's not my insurance, it's not any things connected directly with me. But sometimes the simple fact that I have letters behind my name makes my voice louder than yours. But at the same time, use it, use me. Like, use me for, support, for resources, use my voice to get whatever it is that I can do for you for things like that. So if it's my voice that they, listen to and not yours, I'm all right with that. Use my voice for what that is. Again, that's, using your supports, using any of the resources that they have available to them for these things.
Ashley, we have a question. Do you know if Medicaid insurance covers lactation consultants after discharge? In CARE's experience, if a lactation consultant is needed after discharge, it can be relatively expensive. Or are there any programs that offer this service for our moms who are unable to pay for the service?
So that's a great question. And I'm sure it probably varies a little bit by hospital. We connect and give moms the resource of things like La Leche League, which is a little bit more national, I believe. But at least for the tri-state hospitals up here, they are able to call at any time for support and either get support over the phone, and more over the phone now with COVID for things. So they just call a general number. And honestly, I think up here for the different hospitals, even though they're different, they're all within the Tri-Health umbrella, which has been kind of nice. So they just call one number here to reach lactation for support for that. I don't know what it is for hospitals down in Kentucky, what that would be. But I would think that the lactation consultant at the patient's hospital of delivery would be able to give more information about that. It's also, I guess, highly possible that the HANDS program that you guys have or any other supports down there would be able to either have a consultant on staff or have resources to connect to those consultants. I know that the resource we have up here of Help Me Grow has a lactation consultant, on staff, which is available for use and support and questions and answers throughout that first year for mom. So if the baby does need to be admitted into the NICU, this is something that I learned was a little, not different for down in Kentucky, there's just an additional factor. The educator I spoke with didn't mention anything about a special care nursery. She did mention something called, she said that they do at UK have a NICU for babies that are born with other medical issues or other medical issues with NAS. But she said that for babies that are just born with symptoms of NAS, they have a NACU unit, a neonatal abstinence care unit, where mom and baby can go and stay the entire time for baby's observation and potential treatment, which is really cool. I did not know that was a thing. So that was very exciting to hear. So not all hospitals up here in the Cincinnati area have a special care nursery for that. And the nurse educator gives a little bit more information and clarification as to what nursery would be needed, what level of care would be needed based on what baby might be experiencing and exhibiting. With COVID, I don't know honestly how this has changed in terms of mom staying. I know that some of the NICUs up here are individual rooms. I know that some of them are kind of a big, more open area with like several little pods in between. I don't know what that looks like for mom and staying. A lot of my moms say I'm staying anyway, and I'll stay wherever it is that they say I can stay, but I'll stay. And I've yet in 7 years to get feedback from the hospital or from a mom of being asked to leave for anything of that nature, for being there for that support. So now we start looking into the ongoing care for mom herself and the ongoing care for baby as we move through the postpartum part of it. And all of the things that we've been talking about with moms over the course of the curriculum of ask all of the questions. don't be afraid to take as much control of the appointments that you need to, write down the questions that you have, write down the doctor's answers. It's, it's a kind of a uncomfortable feeling sometimes. If the doctor comes in, it might have their own agenda and has, X number of patients to see throughout the day. So may only have allotted a certain number of minutes for your appointment. But if you've got a list of questions for things, bring those questions. If they're trying to move on through and get out the door, absolutely advocate yourself and be like, well, I've got these questions, and make sure you get answers that you understand as well, because this is your prenatal care, this is your life, this is your baby's life, and these are your futures. So make sure that you get all of your questions answered. And if you feel like you didn't get your questions answered, call. There's absolutely nothing stopping you from calling your doctor after that appointment the same day, the next day, and be like, I asked this and you told me this, and while I was thinking about it, or I couldn't read my handwriting, can you just clarify a little bit more? We've done that. I've done that in session with the patient, so they can use my voice again, or sometimes they're just a little nervous about the question that they have for things. So we try to be proactive, anticipate as much as possible. I don't usually like to play the what if game with my patients. We do talk about what if in a few certain different scenarios, because it's necessary in order to make a plan, know what it is I need to do, what next step that I need to take for my best practice and my baby's best practice for safety and for health moving forward. So the plan of care for the baby while still in the hospital is very, similar to the conversation that we have with mom about her care. Well, it's gonna, from the outside looking in, it's probably gonna have the same foundational aspects. Your treatment here at BrightView is going to consist of counseling. That counseling has a sub-tree of individual counseling, group counseling, meeting with case management, meeting with our peer recovery supporter, and probably has the other option of medication-assisted treatment, different types of medication-assisted treatment, different dosages of medication-assisted treatment. So when you look at it from the outside of, I participate in BrightView, well, BrightView has XYZ factors. One mom may only use factor X and Z, and one mom might only use factor Y, and it looks a little different and kind of the same in plan of care for the baby for things like that. Some of them, are constants. Let baby sleep. That's how they heal, and restore and regenerate for things of that nature. And it's just kind of reminding mom. It can be very easy almost to forget some of the things that seem very obvious in terms of being a mom, caring for baby, but it's very overwhelming, and it's okay to need a little bit of a reminder. The handout that was able to be shared that has the purple crying period on one side, on the back has those reminders of the ABCs for sleep, sleeping on my back, sleeping alone, sleeping in a crib, being in a sleep sack, no loose things. Has the 5 S's, walks you through how to swaddle a baby, because in the midst of baby crying and flailing all over the place, it can be very overwhelming. So sometimes having a nice big visual reminder of take a deep breath, 1, 2, 3, this is how you do it. If it doesn't look like a perfect burrito, that's totally okay. You can either try again, or the non-perfect burrito might work for your baby. Your baby is individualized and is going to figure out and tell you exactly what they do or don't like in their own way. And just, listening to that from baby as much as we can, and learning. And you'll be surprised what you can learn from your baby if you just watch them and listen. And my moms come back and they're like, my baby likes to be burped going up and down like they're a milkshake or something. I'm like, cool, if that works for your baby and we're, everybody's supported and fine, there's nothing saying that your baby has to be, swayed football style back and forth. Some babies don't like it at all and can't stand it. So some of what the things that we try and educate mom is things just to get get used to and potentially be prepared for with an infant. One of the things that is a fairly, common, especially while in the hospital, is with withdrawal and with NAS comes some diarrhea, and that can really start to irritate, baby skin. There can be other skincare changes that need to be addressed, and the nurse educator will bring in, apparently there's a special kind of diaper rash cream that is only hospital grade. That's like amazing and goes on like cement paste and works fantastic. She's like, I put on a layer and lather it up every single time, even if the baby hasn't done anything. I always put on a fresh layer because it's like, she's like, it's like magic. I said, well, where can I get this? She's like, you can't. I'm like, bummer. So making sure that, all of these little things that, diarrhea happens and, diaper rash can happen. Well, remember, everything's a little escalated, a little elevated when it comes to NAS. So to prepare for, since it's a possibility, let's decrease the possibility of it as much as we can. And if it does happen, let's decrease the impact that it will have negatively. So right when we are, right when we're finishing part of our pregnancy program with mom within the group, is, going over some of the highlights and giving some extra support and some extra attention to, the part that I've noticed and we've noticed over the couple of years, and working with moms and taking their feedback of what they either wish we talked about even more, or what, little reminders to have. So we always make sure that we go back and, let mom know, hey, it's an option that baby is going to experience withdrawal. I think once we start talking about it, something kind of flips in mom's head of like, oh my gosh, my baby's going to withdraw. It's a possibility. And reminding them that this 50-50, like, well, there's a 50% chance that they could. I'm like, well, there's also a 50% chance that they could not. And that 5 days in the hospital is just 5 days in the hospital. And bringing that, reminding them of the, there's lots of positives that are going to happen here. You're about to have a brand new baby who is, awesome and yours, and you've been waiting to meet for so long, and see what they look like, and if they have hair, or if they've got 6 chins as opposed to 2, depending on how chunky they are, and you get to know them. They've gotten to know you for a really long time. So let's not miss this great thing that's happening because of the possibility that something could happen. If that possibility happens, remember, these are all the things that you can do. You can do the skin to skin, you can breastfeed, you can do all of this planning. Let's not forget and get, caught up in all of the, I don't want to say like hubbub, but kind of like get caught up in all of these things and forget some of the basics. Don't forget your own self-care. Take a nap when the baby naps, Try and take a shower, eat, drink some water, follow up with your prenatal care provider, follow up with your treatment program here. If you have questions about anything, call. I think, reminding mom that she has a voice, and she may need support is totally fine, regardless of if she's in recovery or not. Having all of these things in play, and knowing that you have supports out there that are, waiting for you to reach out, and just, ready to jump as soon as you ask, is a really calming factor for mom in a time that is very stressful. That stress doesn't necessarily have to be a negative thing whatsoever. That stress can absolutely be a jumping board forward to making, strong progress, strong memories, and having healthy futures for everybody involved. And that is, if anybody has questions or wants me to go back for anything, we've got more time than I thought we would have. So I'm happy to answer questions, or if we want to have discussion. Ben, I don't know what the plan is after this.
Yeah, we're ready to take questions and talk about your presentation. I thought it was really, really informative. I had no idea that MAT could go on while you were pregnant. I would have thought, if you just asked me before this training, I would have thought that you couldn't do that.
Yeah, we try and think about it as kind of a bigger picture type thing. How would stopping your MAT in general, let's say you weren't pregnant, how would stopping your MAT be a beneficial thing for your recovery? And sometimes we're able to brainstorm, how it is beneficial and how it would not be beneficial. Like, okay, now that you know all of those things, tell me how it would be beneficial to stop MAT for your recovery now that you're pregnant for things. And we kind of brainstorm and talk through all of those pros and cons and stuff. Our provider does not recommend, tapering down off of medication while pregnant, but sometimes the patient decides that that's what they want to do. So then we have to try and figure out a plan how to get them safely as much as possible to do that. So that's where the ROIs, and we will reach out to their prenatal provider and be like, hey, they're saying this, we recommend against it, but I can't control what they're going to do at home and things of that nature. So making sure that they always have the education about it for everybody's health. Yeah.
Ashley, my name's Patty Rohr. So I'm totally not CASA or anything. And I'm a supervisor of drug court in Kentucky. And this training was super informative to me. We just now got BrightView in our county, in our city. So I'm super excited about that. But one of the things, I did send you a private message just because I felt like it was more appropriate to send it to you. If you have, or if anyone has a compounding pharmacy close to them, almost every compounding pharmacy I've come across makes their own type of rash cream. And my judge actually got it for me when I had my son, who will be 7 next week. And it is like liquid gold. It is the best thing ever. So if you have a compounding pharmacy, you can just Google compounding pharmacy and your city or county or whatever, and it should come up. But they typically make their own, and it's good. Like we keep it on hand. We have 15-year-old twins, and my son will be 7 next week. And we keep it on hand because it really is good for any type of skin ailment. So that might be something in your area you could look for just to help with the horrible rash that can occur.
Oh, that's fantastic. Thank you, Patty. I definitely will make note of that to share with my case manager to see if there's a way that we can find and tap into that resource.
Yeah, there's no prescription needed for it since it's made there. And I guess none of the components of it are technically, anything that would require a prescription. Nothing's controlled. But it looks almost for us ladies, that wear foundation, it looks like foundation. And trust me, when I opened up the jar the first time, I was like, what am I putting on my kid's butt? But it he had never gotten a rash. I put it on, and within, no lie, no exaggeration, within 15 minutes, the rash was gone. By his next diaper change, it was completely gone. And like the nurse told you, lather it on just to kind of prevent, as a preventative measure, if they're having some type of issue that would cause a bad rash in that area. So yeah, certainly look into it. It may be of big benefit to your clients.
That's awesome. Thank you so much.
I'm really happy I could share something from even though I come from the criminal justice perspective in this training. BrightView sent it out to me yesterday, and I'm super glad that I got to participate. So thank you.
Yeah. For those of you guys who don't know, a lot about BrightView, we've been open for about 6 years. And just very recently, we've been able to expand into Kentucky. For a long time, we were just in the state of Ohio, and we now have across the two states, 32 centers, including, down in Louisville and Zanesville and Nicholasville and Paris, down there in Kentucky, and we're all the way up in northern Ohio in terms of things. Canton, Akron, a couple in Columbus, Georgetown, trying to make ourselves as reachable as possible for lots of people in need, because since the disease has no boundaries, we kind of are trying to take the same approach. So that's awesome. I'm so excited to hear that, Patty, that one of us is close to you.
Yes, the Nicholasville and Paris locations. Paris was
Yes.
actually in one of the counties we serve, and Nicholasville is in adjacent county and a county that we're soon hopefully going to have CASA services in.
Fantastic.
Yes, mine is Nicholasville, and we've been fighting to get CASA in Jessamine County. So please, please, please come. And I will do anything I can with the court system to help get that along its way. But Nicholasville is my location, and I've been in constant contact with Nicole Stinson, the outreach coordinator there, and it's a blessing to our area. We're very excited, and we'd love to have CASA.
Wonderful.
We're working on it. Are there any other questions?
Ben, were we able to share, or I guess Nikki, were we able to share those two things that I sent that I was referencing for the last 2 hours? Because if not, that really is unfortunate. Everybody should not know what we're talking about.
Yeah, everyone has it, and so Sarah's holding it up. She printed it out.
Oh, wonderful. Okay.
Yep.
That makes things make a lot more sense then.
Yeah, I found that Finnegan scoring tool very interesting.
Again, I don't know if different hospitals have a different printout sheet for that. Finnegan scoring doesn't vary a whole lot. It might look a little different, but I would think that the core foundation things of what they're looking for would probably be generally the same. But I would also think that if you just reach out to your local hospital, they hopefully would be willing to share that resource with you so that you can continue the education.